Good afternoon, and welcome to the last session of the 2024 FPA Virtual Conference. We're very happy to welcome Dr. Lauren Levy and Dr. Asher Mansdorf, who will discuss the language of orofacial pain, describing facial pain to your practitioners. This will be a very interesting presentation, so I'm happy you're here. Before we get started, I'd like to go over the housekeeping items one last time. If you have questions, please add them in the Q&A feature on the right side of your screen. Let's save the chat feature for attendee connections and conversations. I'll do my best to monitor both, but that will make things easier, and hopefully we'll get to more of your questions if we do it that way. Following Dr. Levy's and Dr. Mansdorf's presentation, we will get to as many questions as we can. Please understand that our doctors are not able to answer specific questions about your situation. However, we will ask general questions applicable to the most people living with facial pain. Now I'd like to introduce our speakers. Dr. Lauren Levy is a board-certified orofacial pain specialist and fellowship-trained dental oncologist who has dedicated her career to treating and managing head, neck, and facial pain, as well as sleep-related breathing disorders and oral medicine-related conditions. Dr. Levy has published articles in multiple journals in the fields of pain and oral medicine. Her research interests include TMD and migraine, the use of neuromodulation in the treatment of orofacial pain, and the applicability of photobiomodulation in the treatment of radiation fibrosis syndrome and trigeminal neuropathic pain. Dr. Asher Mansdorf is a clinical assistant professor at the Touro College of Dental Medicine and co-director of the TMD and orofacial pain course. He is a dual board certified in anesthesiology and orofacial pain. He received his DDS from Columbia University College of Dental Medicine. Due to his strong interest in pain, Dr. Mansdorf received a Master's of Science degree in pain management from the University of Southern California. Let's get to our speakers. Dr. Levy and Dr. Mansdorf, please go ahead.
Thanks for having us. My name is Lauren Levy. I am the Director of Orofacial Pain, Headache, and Sleep at Touro College of Dental Medicine. And today we're going to be talking about the language of orofacial pain. Dr. Mansdorf, I'll let you introduce yourself.
I'm Asher Mansdorf, and I am Dr. Levy's sidekick. And with that, let's just get started. So facial pain, orofacial pain, is to most patients and to many, many practitioners an incredible puzzle. And they come in, the patients come in, and the practitioners listen to words. And they try to put those words together to solve the puzzle. So the question is the pain radiating or sharp? Is it vice-like or shooting? Is it burning or electric? Is it throbbing? And you know that not all the words are out there in this puzzle. So the question of how to proceed is basically filled in by this quote. It's identify the essential, those points that will make a difference to assisting the practitioner to help to determine the causal agent of your pain, or to help the practitioner, if they can't determine the causal agent to your pain, find a pathway to allow you to eliminate the pain or moderate the pain or control the pain. So my story starts back with Dr. Joseph Bell. Dr. Joseph Bell is known as the father of forensic medicine, a British physician who secondarily was the mentor to Arthur Conan Doyle, the author of Sherlock Holmes. And when he's a trained ophthalmologist, or he was a trained ophthalmologist, who trained under the father of forensic medicine, and watched how he searched the mysteries of the patients that he saw who could no longer communicate, or those who could communicate, to find the causal agent for their discomfort. And here's a story that he quotes. And I'm not going to use a Scottish accent. Well, my man, you've served in the army. Aye, sir. Not long discharged? No, sir. A Highland regiment? Aye, sir. A non-com officer? Aye, sir. Stationed in Barbados? Aye, sir. How did he know that? How did he know that? before the patient said a word. And he explained. The man was respectful, but did not remove his hat. They do not remove their hat in the Army. But he would have learned the civilian ways had he been long discharged. So he inferred. He had an air of authority, and he is obviously Scottish. As to Barbados, his complaint was elephantiasis, which is West Indian and not British. And as a result, he began to look past the patient to help determine what the problems were. So if I can impose on you, and if you have a phone, if you could scan the QR code, and if you could participate in this presentation with Dr. Levy and with me, and if you could add in some responses to what do you think it means when a patient says they're numb? And we'll wait a few minutes. Hopefully people will respond. Just scan the QR code and your responses will show up. Okay. So we only have one response. I'm going to move on to the next. Oh, we have another one. Thank you, everyone who's responding. And while the responses are continuing to come in, I'll share a story with you. So I had a patient come into the office who said, something is wrong. I feel numb. And as a result, the very first thing I thought of was the sensation you feel after you deliver a local anesthetic. So I checked for numbness. So how do you check for numbness? You check for sharpness. You check for dullness. You check for thermal sensation. Those are the things that you check for. So the lip on the right felt exactly like the lip on the left to a sharp object, the tip of a needle. The lip on the right felt exactly like the lip on the left to a cotton swab. The lip on the right felt exactly like the lip on the left to cold. And the same thing was true of heat. So the question I asked myself was, are they really numb? But they have an altered sensation. So it means going past what the patient said, not using your preconceived notion as to what numbness was. In this particular case, the patient had an issue that caused them to lose proprioception, the sense of where their lip was. Not hot, not cold. So although numb was the tent meaning, the specific meaning was incorrect. Let's go on to the next. What does it mean when a patient says they have pain? Dr. Levy, you want to take this one?
Sure. I guess we still have people filling in, but I think what was interesting about our previous question, and even of course with this question, and why we asked it is, numbness can mean a lot of different things to a lot of different people. It can mean a total loss of sensation, but it also, like we were saying, it also can just mean an altered sensation, like when you're getting anesthesia. So just to review some of these comments, it says pins and needles, something hurts, electric shocks. So I think it's clear as the responses are coming in, and thank you everybody for being so engaging, is that it's very, and what we're getting at is it's very hard to define pain, and pain can feel very different to different people. depending on the type of pain you're feeling and for how long you might be feeling it.
So terrific. So one patient said agony. The other patient said unpleasant feeling. That could be the same exact thing, but different for different people. So let's keep moving. Thank you very much, everyone. So Dr. Thomas, who's a mentor of mine and Dr. Levy's, shared the following case with us. A 29-year-old female presented with a chief complaint of clicking of the jaw and bilateral pain. Unfortunately, the minute that we hear that, we start to paint a picture in our own mind, even before we see the patient. The timeline was it began many years ago. And then, of course, you say to yourself, why now? Why did the patient present now if it began many years ago? Here's the answer. Recently, the pains or the annoyances or the clicking became more intense and with greater frequency. And that was over the last 4 or 5 months, even though the problem went on for many, many years. Nothing actually caused the change in this patient's mind. The area that they pointed out was preauricular, just in front of the ear, consistent with a joint issue. It was daily and continuous. It was aching and pressure-like, and at times it became worse. It was continuous 6 out of 10, but when it got worse, it was 8 out of 9 on a scale of pain of 0 to 10. The aggravating factors were jaw function, chewing, and eating. Stress was identified as a precipitating and triggering event. All of this is already painting a picture in the practitioner's head. And I would think probably painting a picture in yours. And then, of course, rest was a relieving factor. So now there's already a picture painted, but our job is not to be taken in by the picture. So now he continues. The patient consulted a dentist because we all know if you have a joint discomfort, go to the dentist. The dentist went ahead and followed the path, correctly so. Trigger point injections, mandibular splint, anti-inflammatories, and physical therapy. Exactly what we would all expect. It didn't help. Now what? The patient presented with exactly what we thought they would present with, and we gave them the therapy that should have helped. After 4 or 5 months of treatment, now let's recall, the exacerbation started 5 months before the presentation. Now this is 5 months later. So the patient's now been in greater pain for 10 months. They referred to an orofacial pain specialist. Now, what did the orofacial pain specialist do that was different? What that pain specialist did was that pain specialist did not allow themselves to fall into the trap of painting the picture and not saying that there aren't other pictures in the exhibit. They went through the history in a little more thorough manner. They now know that there were headaches and they were on for several years. The headache was not associated with any specific event. The headaches had more locations: back of the head, neck, and temple. Now there are other pictures you can start to paint. The jaw pain could be at the same time or not. The frequency was 3 or 4 times a week of the headaches, which could last several hours. Now, once again, there's another picture in this exhibit. The frequency incurred over the years and then stabilized. The pain was achy and pressure-like, and 5 out of 6 of 10. There was nothing that they could say aggravated it, and there were no associated features, no autonomic signs. I know you had a great lecture on autonomic signs. Now let's move forward. They also figured out that the patient had a restorative sleep issue, that she had pilonidal cyst surgery, that she had hair that grew in inappropriate places but too much, and had an irregular and painful menstrual cycle. The ultrasound of the ovaries saw the appearance and disappearance of cyst-like follicles. Once again, you automatically start to paint a picture in your mind of an ovarian disease. That patient had iron deficiency, temperature sensitivity, dry skin and cold extremities, global pain and excessive fatigue. And now you're saying there is more to this story, or we all should be saying there is more to this story. Unexplained self-resolving episodes of sore throat. You would expect a positive fibromyalgia screening. You wouldn't necessarily expect a positive hypermobility screening, but there it was, and the psychosocial history was unremarkable. Achy and pressure pain, 5 out of 6. No aggravating factors. Now, the orofacial pain specialist decided to do diagnostic testing appropriately and did a CBC with DIF, a CMP, an anemia panel, ANA, CRP, and ESR. They also found that the patient had fluctuating thyroid hormones, T3, T4, and TSH, and actually was then diagnosed with euthyroid or sick thyroid syndrome. Say that really quickly 3 times. A high EBV titer, a high CMV titer, and 2 types of Lyme. Dr. Levy, I leave it up to you now.
Yeah, so just to kind of review the diagnostic testing a little bit, this is common testing that's done often when we are looking at patients and we're scratching our heads and, thinking that it's not just maybe muscle pain as what was initially thought. So CBC with differential just stands for complete blood cell count with differential. That looks at your white blood cell counts. It looks like your platelets. It looks at your red blood cell counts. And the differential means that it specifically looks at different type of white blood cells. The CMP is the comprehensive metabolic panel that looks at things like chloride and sodium. The anemia panel often goes on with that, but it's just looking more specifically on the type of red blood cells that you might have in terms of shape and how well they can be packed together. ANA is a non-specific marker that can be elevated in autoimmune conditions. CRP and ESR, you may have heard of ESR, also known as SED rate. Those are both non-specific markers of inflammation, but when they are elevated together along with ANA, they might indicate an autoimmune condition. They also might be elevated in other conditions as well. So alone, one number is not so significant, but together they mean something. TSH is the thyroid stimulating hormone. So that relates to T3 and T4, which are released by the thyroid. EBV stands for Epstein-Barr virus. And if you have a high titer, that means that you were exposed to the virus. So that is the virus that's implicated in mono. It's also implicated in or related to potentially nasopharyngeal carcinoma. So like I said, just because your titer is high doesn't mean you actively have the infection now. It might just mean that you once had it or were exposed to it. CMV, same thing, another type of virus, cytomegalovirus. Just because the titer is high doesn't mean you actively have it. It might just mean that you were exposed to it once. And then in terms of Lyme, in order to technically have Lyme, you have to have a certain number of immunoglobulins that are elevated, also known as antibodies. So if those numbers are high now, it could mean that the patient actively has Lyme and later on more numbers are going to become up, or maybe they were recently treated for Lyme where they're fighting against Lyme and then those numbers are slowly going to go down. So realistically, from these, we would probably have to get even more testing.
So what Dr. Thomas decided to do was he decided to pick up his magnifying glass. See, I use props. Pick up his magnifying glass and made a decision to be Arthur Conan Doyle-like, Sherlock Holmes-like, not to be fooled by the fact that somebody walked in, left their hat on, and that they simply weren't nice because they didn't take their hat off, but instead said, why didn't the patient take their hat off? So why didn't this patient get better? Now, if you're all waiting for what was done for this patient, so am I. When I said to Dr. Thomas, what did you do eventually? He said, come to the next lecture. So when I know, you'll know. So let's move forward. Really, what is orofacial pain? So recently, in the last year or two, orofacial pain has now been classified, and it's been classified into 39 separate events in 6 major categories. And that's because classification, as they say at the Jefferson Medical Center, helps us to better diagnose headache disorders and ultimately treat them properly. So if we can classify them, we ought to be able to treat them simply because we have a pool of evidence as to how each one of those should be treated. And so these are the 6 categories. And the 6 categories break into orofacial pain attributed to disorders of the dentoalveolar and anatomically related structures. That means teeth and jaws causing tooth and jaw pain. Okay, or we have myofascial orofacial pain, the muscles of the face causing pain. Now, muscular pain in the face can either be at the site of the pain, that means right here, or it could be that when you press here, it hurts here, or it hurts there. And knowing that helps you to treat it. Or it could be TMJ pain, the classic TMJ pain. And once again, why is it there? Where is the pain being sent to? Or it could be attributed to a lesion or disease of the cranial nerves. There are 12 cranial nerves. So my patient who presented with numbness, their problem was with the 12th cranial nerve. It wasn't with the 5th, which is normally associated with the face. And then, of course, we have orofacial pains resembling presentations of primary headaches. Headaches, many of the headaches can refer pain to teeth. Many of the teeth pains are not the result of teeth, but they're the result of headaches. And then you have teeth pains that are teeth pains that mimic headaches. And then, of course, we have idiopathic orofacial pain. And there, it would be appropriate in parenthesis to say why. And one day we will know why, but right now, we often just simply take a guess at why, whether it's Bernie mouth syndrome, persistent idiopathic facial pain, persistent idiopathic dental alveolar pain, and constant unilateral pain. So the American Board of Orofacial Pain takes pains to define it. And what do they say? They say this pain is perceived in the face or oral cavity. It's not necessarily in that region. It could be a disease or a disorder of the regional structures, the result of dysfunction. And it could come from a faraway place and end up in your head and neck. So let's go to a specific case, the toothache that will not go away, where the patient says, my tooth still hurts. Everyone says that I can't have the pain in this tooth. We've all gone through something similar. It doesn't have to be a tooth. I can't have the pain in my arm. I can't have the pain in my leg. I can't have the pain behind my ear. And then you start to think that people think that there's something wrong with you other than the tooth, that you're making it up. So I want to thank Dr. Syrup, Stephen Syrup, who's a terrific mentor as well, for sharing this case with us today.
September, I had a filling that was loose and had it refilled. I had a little bit of burning before it was refilled. After it was filled, the burning started again, and it's got worse and worse and worse, and no one could do anything. And then I was told I needed a root canal. Had a root canal, made it worse, burning, fire. Felt like my mouth was on fire, knives cutting at me. Then they had to pull the tooth, and since they pulled the tooth, it's been twice as bad, and it's burning, throbbing on the teeth around it, burning on the gums all the way across to the left, burning in the tooth, and just fire, constantly on fire. And like people are just cutting at me with knives, like somebody cut me open and never put stitches in. And sometimes my whole jaw aches for no reason.
So here's a patient that painted a picture, that went to their dentist. The dentist followed all the appropriate steps. And ultimately, the decision was there had to be something wrong with this tooth. But when it's a tooth, ordinarily, when you remove the ability of the tooth to feel, which is the neurovascular bundle within the tooth, when you do the root canal therapy, pain shouldn't continue. And that's a cardinal sign that stop, reevaluate, bring out your inner Arthur Conan Doyle. Become a medical Sherlock Holmes.
I've been in pain for 3 months. I couldn't eat, I couldn't sleep, I couldn't brush my teeth, couldn't floss, I couldn't even drink water. I finally went to a doctor who diagnosed it, helped me out. We started off with 1 pill a day, gradually worked up to 9 pills, but now we're gradually working down, which is, fortunately for me, that's a good thing. The other day I heard someone singing, and it was me.
The first time I heard this tape, it brought tears to my eyes. She's heard someone singing, and it was her. And you can actually see the difference in her face because somebody brought about a solution for her. They didn't tell her why she had the pain. They just said, we're going to find a different way to help you conquer your pain. And that made a difference. The inner Arthur Conan Doyle. So she was on pain meds she was on meds, neuropathic meds for 9 months. She was reducing it. And then in order to replace the tooth, they made her an appliance. So now start to ask yourself these questions and share these responses with your care provider. Say to yourself, is this chronic? Let's go back to the patient Dr. Thomas saw. It went back years. Although it was 5 months that the pain was more severe, the pain was really chronic. Is it infectious? Think to yourself. Is it something causing the pain? That means, is this tooth that's infected on this patient's lower left in red the actual source? Is it inflammatory? That means, is there something in the mouth or something in the head that is sending out signals of pain simply because it's inflamed? Is it musculoskeletal? I love this picture. Look how the face is a hammock of muscles. Any one of those muscles can contribute. Is it orthopedic? That means, is it arthritic? Is there something in the joint? We never find it unusual that a pitcher hurts their shoulder, or a runner hurts their knee, or a tennis player hurts their elbow. We have to think that way. And now think of the words that you use when you share your symptoms. Is it achy, or heavy, or dull, or throbbing? If it is any of those things, you begin to think of musculoskeletal pain. Is it shooting or sharp? Electrical, hot, burning, or radiating? If it is any of those things, you begin to think neuropathic. Is it a dull ache with pressure and throbbing? Does it wrap around the head? Is it squeezing in vice-like? You begin to think of neurovascular disorders. The many, many, many headaches that are out there. So now the question is, what is neuropathic pain really? Where does it take us? So it breaks into nociceptive pain and it breaks into neuropathic pain. Dr. Levy?
Yeah, so when we talk about pain, we can talk about it, as Dr. Mansdorf mentioned, in 2 ways. We can talk about it as nociceptive pain or what we might call healthy pain. And we say it's healthy because it's protective in nature. So if you touch a noxious stimuli, like something sharp or something hot, your body will tell you it's painful so that you stop touching the hot thing or the sharp thing so that you don't lose your hand, right? And it's mediated by 2 primary afferent neurons, meaning two neurons or 2 nerve cells will will respond to that noxious stimuli, right? And in order for it to get to the brain, it has to go through synapses, which, as you can see here, right? So it goes through a synapse and the neurotransmitters get released through, right? So there's 2 main primary afferent neurons. There's the A delta fibers and the C fibers. A delta fibers, meaning that they have a little bit of myelin on them. C fibers do not. And they are responsible for most pain that you feel, right? And they're responsible for nociceptive pain. Now, neuropathic pain is the other type of pain that we don't totally understand. But what we do understand about it is that it's caused by some sort of dysfunction in the nervous system. And everything is really hyper excited and a little bit almost like irritated, I would say. And so as a result, even things that are not noxious, meaning like a gust of fresh air, can drop you to your knees because that can be considered painful. Or putting a shirt on, not normally painful. When you have neuropathic pain, it might be painful.
So nociceptive pain, I like to reach back to the movie or the Broadway show called The Sunshine Boys, which with George Burns and Walter Matthau, where they reenact a vaudeville scene. They're sitting on a stage. One's a doctor, one's a patient. And the patient says to the doctor, doctor, hurts when I go like that. The doctor says, don't go like that. That's nociceptive pain. It's your body saying to you, don't do that. That's just not a good idea. Neuropathic pain, on the other hand, is a pain that we truly don't understand. Now, personally, I think what's going on is that the body still is on guard. The body still senses a threat. And it doesn't know that the threat has gone away. So it keeps telling you, don't do that. We just don't know why it's telling you not to do that. If we could figure that out, that would make a tremendous difference. But right now, our approach for the most part with neuropathic pain is to control it. And there is a significant emotional component to neuropathic pain. So that has to be brought under control as well. So in order to do this, in order to help ourselves take the Arthur Conan Doyle out and put it on the table, to take our magnifying glass and use it, we have a set way of acquiring information. And Dr. Levy is going to go over that with you now.
So I think we would both say that, 90 to 95% of a diagnosis is getting a really good history. And that's why we thought it was so important to label this lecture as describing your pain, right? So in addition to you being really good at describing your pain, the provider also has to ask the right questions. So first question, of course, would be, what brings you in today? Tell us about your pain. Where does it hurt? And what does it feel like? How would you describe the quality of your pain? Is it sharp? Is it shooting? Is it electric? Is it dull? Is it aching? Is it throbbing? Is it pulsating? And do you have any other kind of head and neck pains associated with this pain? So headaches, of course, is an easy one that we always ask about because sometimes patients have underlying headache disorders that might be responsible for some of their pain. And it takes a little bit of time for us to put the pieces together. Sometimes asking if a patient has a history of migraine, we realize, oh, wait a minute, they have migraine. Perhaps migraine in this situation is presenting in a different area of their face. And, that's just kind of an overview, but we do make sure to go over all of these questions with patients. And hopefully it makes it a little bit easier for you to understand why it's so important for providers to be asking such a detailed history. So we ask patients, what makes their pain better? What makes it worse? Do they have a family history of any of these types of pains? Meaning, migraine and cluster headache, they both run in families. So if someone in their family has that, there is a better chance that maybe the patient has that too. Any recent travel, so that previous patient had 2 positive elevated numbers for Lyme. Perhaps they spend a lot of times in the woods, or maybe they ate puffer fish, or they ate something or were exposed to something in a different country, in a different region that might help give us a clue. We also ask about sleep. Do you wake up feeling rested? Have you ever been told that you snore? Do you ever wake up gasping for air? It's very hard to get out of pain if you don't have a good night's sleep. So are you in chronic pain because of a sleep disorder, or is your pain condition making it so it's hard for you to fall asleep?
So there's a terrific podcast series out of Boston Children's Hospital. And you'll see the quote on the right. You'll see that I read very well. I'm able to read the quotes. There are multiple drivers of pain. Each one has different features and requires different therapeutic strategies. And the only way we know that is that our breakthrough to understanding your pain begins with a series of questions. So I'm just going to relate a story to you. So I go to synagogue every Saturday, and there's a social hall. And in the social hall, there are people who are praying, and there are doors. And when the rabbi gets up to speak, they always try to close the doors. And when they close one door, another one pops open. There's no moral lesson in what I'm telling you with this. When they close one door, another one pops open. And if you hold both doors shut, it takes a great deal of work to close the doors. And what's the first thing everyone thinks of? They were too cheap to fix the locks. Why didn't they fix the locks? If they only fixed the locks, they would be able to cure this problem. to take away this pain, to take care of this dilemma. Great. So I said, fix the locks. And they said, we changed the locks 3 times. It still happens. But then I noticed that when you open the back door, the front doors didn't open. So I asked someone, why would that be? They said, oh, when they redid the social hall, they put in a brand new ceiling. When they put in the brand new ceiling, they covered up the air returns. When they covered up the air returns, the air conditioning pumps into the room, but the air has no place to go. And as a result, it blows the doors open. So the pain was at the doorknob. The therapist who was deciding how to fix it fixed the doorknob. But this was from a distant source. It was from the ceiling. So we have to fix the ceiling in order to fix the door. So what you need to do when you go is you have to say to yourself, is my pain here? Or is my pain here and my cause is someplace else? So remember, every breakthrough begins with a series of questions. It's the words that are important. It's the words that you are asked, and it's the words that you respond with. Bring out your and your practitioner's inner Arthur Conan Doyle. I want to thank you all for allowing me to speak. I won't speak for Dr. Levy. She'll thank you on her own, but it's really been an honor to have the time to speak with you, Dr. Levy.
Yeah, thank you so much for having us speak. Hopefully this was valuable. We know that it's an honor for us to speak to you.
Well, thank you both for speaking. This is a great presentation. I got lots of comments and we do have some questions. So I want to go ahead and get right to those if you guys don't mind.
Dr. Levy answers all the questions.
So I thought this was an interesting question. What if pain elements vary from those you mentioned? Do you just tell the doctor all of them? Like, how do you decide?
Yeah, I think that even if you think it might not be relevant, it might be relevant. So I don't think there's any reason not to. You know, if you have aches and pains elsewhere in your body, especially if they're new or recent, I would mention that to your doctor. Of course, if your doctor's asking about it, don't make the assumption like, oh, it might not be relevant, because it might be.
Great. Okay. This question is interesting too. Can you suggest how to use the pain scale when you're in constant pain? That's not something that you necessarily talked about today, but might be another way to communicate that pain. Is that something you would suggest?
Yeah, I mean, sometimes when we ask patients that, when they have constant pain, sometimes there are fluctuations in their pain. So they might say, you know, right now I'm at a 4 out of 10, but when it gets really bad, I'm at a 7, or when it gets really bad, I'm at an 8. So you don't necessarily have to give one number. You can give, you know, a few numbers depending on how it feels. Of course, if it's always a constant 7, then it's a constant 7.
Correct.
So for example, if you have hemicrania continua and you don't mention that your pain is constantly there as background pain, and you only speak about the paroxysmal episodes, then instead of thinking hemicontinua, you think of paroxysmal. No good. You have to say it. So, and you could just say, I have constant pain, but I have breakthrough pain.
Sure.
But say it.
Okay. This question's a two-parter. So this person asks, can you speak to how a patient that has all the symptoms of geniculate neuralgia should proceed to be worked up for that diagnosis? And then it moves into a question about the upper cervical spine. So let me just address that part first.
So I guess the thing with that would be if it's just geniculate neuralgia alone, or if it might be more of like a Ramsay-Hunt syndrome situation, in which case Ramsay-Hunt, there's a triad and it's believed to be associated with the herpes virus. So really a thorough head and neck exam is key here, because there are a lot of things that might mimic geniculate neuralgia. But if you really think that that is the case, then imaging would be appropriate, as well as some baseline labs as well.
And that might lead to the second part of this question, which is, what are your thoughts and experience for upper cervical spine instability mechanically causing the GN pain, potentially from the cervical nerve roots exiting the spine being impinged? She says, I've been suffering with this for years, only got relief from the GN pain from physical therapy, strengthening the upper body.
So I guess that's hard to say because, without a thorough exam, it's a little bit more challenging. I will say that just broadly, though, that there are many conditions where the head and neck, or sorry, the shoulders and the neck will refer upwards and cause pain that way. And the head and neck and shoulders are all, obviously they're connected, but they really are connected when it comes to pain conditions. So there is something called myofascial pain syndrome where the pain will refer up. There's also another condition known as neck tongue syndrome, which I know that in this situation, geniculate neuralgia is really associated with the facial nerve. But in that condition, there are, pain that you have in your tongue that is related to the neck. So I think it really all goes down to just doing that really thorough head and neck exam and history. And it's okay if one diagnosis started as one thing and changed, right?
Mm-hmm.
So maybe it started as being something and then physical therapy helped, and maybe that helps change our diagnosis a little bit.
So that's interesting that you say that, because there's a question here about starting with, this person says, I started with classic TN on the left side. 5 years later, it went to bilateral. And 4 years from that, they developed occipital neuralgia. And could the occipital neuralgia be a digression of the original TN, or is that a separate diagnosis? Which is difficult to answer, I know, but.
Yeah, I think that one I think that's a challenging one to say. I guess, again, I guess for that one, it would probably be harder to say without really seeing the patient and being able to see how they responded to the trigeminal neuralgia medications, how it really classically described, or maybe they developed something separate. I think, right, Dr. Mansoff, what do you say?
I went through phases when I had pain. I started with back pain. It went through, I don't care what it is, get me out of pain. It was, thank you for getting me out of pain. How long do I have to keep taking these medications? Then it was, what is it that I have exactly? And I finally realized that I don't really need to know what I have, but I shouldn't think that I have one thing. There is no reason to think that a body such as ours is one thing. It's very unusual that you'll go into a fancy restaurant and order only onion rings. It's not one thing, right? You get onion rings, then you look over, whoever you're there with also has French fries, they have potatoes, they have hash browns. It's a menu. So do not think that if you have TN, that's it. Although I hope that you don't have TN. I hope you don't have occipital neuralgia. I hope you don't have any of them. But do not force yourself to be in a bubble of one item. You have to allow yourself to look further and further.
Okay. I think that might answer this question too. How would you describe facial pain that has electric shocks only in the ear canal, no other parts of the face, but also has pain in the eye, in the eyeball? Specifically, an artery is looped and touching TN, MVD did not relieve the pain. But does that kind of have the same effect where it's not just one thing?
The ear is an incredible place. It has multiple cranial nerves, the ear. It's not one. There are so many cranial nerves in the ear. So it requires a really thorough exam.
Okay. This is a very general question, but I think it's a good one. How do you find a physician or dentist who is willing to be a Conan Doyle?
Oh, that's a great question.
I think you start with the American Academy of Orofacial Pain, at least when it comes to head and neck pain. You'll see that there are dentists there that are either board certified in orofacial pain, or they're, at least strongly interested in it. So I would start there. There is also the American Board of Orofacial Pain, where those are all boarded in orofacial pain. So they would have, similar philosophies that Dr. Mansoff and I have.
The people who presented in this weekend's seminars, I looked at those PowerPoints. They're all terrific. So you have that 5-star restaurant menu to choose from. It's there.
And I do think that I often tell people when they're looking for people who are familiar, dentist professionals who are familiar with TN and with facial pain in general, to go to the American Academy of Orofacial Pain, because that specialty really does speak to that
By the
area.
way, just as important with the dentists is that they want to do more. It is
Mhm.
equally important that they say to you, I don't know the answer.
Hmm.
You don't want somebody who says, oh, I know what it is. You need a root canal. If they don't know that you need a root canal, you need
Right.
to find somebody who's so comfortable in their skin that they say, I'm not the one who can help you, but I will work with you to find somebody who can help you.
Hmm. Excellent. I thought this was an interesting question. What can you do if you're on medications for neuropathic pain for another condition, but then pain starts in your face? The medication you're taking for the other condition can mask the pain and interrupt the diagnosis and delay proper treatment.
That is true, but actually sometimes the medications used for neuropathic pain and other conditions can sometimes be used also
Mm-hmm.
for neuropathic pain in the head and neck,
Mm-hmm.
instead of just adding another medicine.
Yeah.
When Dr. Levy was down at Jefferson Headache Center, there were times that patients were hospitalized and put on a medication holiday. And when they're on that medication holiday, they clear everything out of the system, and then they start to rebuild the case from scratch. And sometimes that's the only way.
Okay. Dr. Levy, I don't know that this is necessarily a question that is specific to this talk. However, photobiomodulation was in your bio, and so this question has come up. Could you tell me more about photobiomodulation for TN? A newly qualified dentist friend told us there are promising results, but that it's a new approach. Do you have data on the success or otherwise of this treatment?
Yeah, so that's a good question. So, I will say that photobiomodulation is relatively new.
Mm-hmm.
And that's part of the reason I'm interested in it.
Mm-hmm.
But there isn't the literature, the verdict is not out there. It does seem to have a lot of promising, it does seem to have a lot of promise, right? Like we see that patients with mucositis, also known as mouth sores secondary to cancer therapy, respond really well and actually don't get as much mucositis. We've also seen that it might help with some sort of head and neck pain regarding muscle pain. I think the verdict is still not totally out there for neuropathic pain. There are some early studies that say that it might be helpful, but the reason I'm interested in it is because we still don't totally know yet.
Okay. Excellent. This is another one I'm going to ask that's not necessarily.
At times, photobiomodulation could be like chicken soup. That means it can't hurt.
Okay. This question has shown up in a couple of different talks that we've done. And so again, not necessarily describing pain, but could there be a misdiagnosis? And I know that you guys talked about the importance of being diagnosed correctly. So this woman has had pain and was diagnosed with shingles, but hasn't ever had any blisters or spots. Is that possible to get that diagnosis without the blisters or spots, or could that have been an incorrect diagnosis?
So there is something called herpes synherpetae, which means that you have a herpetic, activation or virus or response without the lesions. So it is more challenging, but you can technically have shingles without the lesions.
Okay.
So it is possible, yeah.
Yeah. I think this is an excellent question. Facial pain sufferers typically have long, winding stories of care and treatments that have been tried. Physicians are often not patient to hear the tales. So is there a way to open the discussion with the doctor so they don't get impatient as facial pain sufferers explain their journeys, because all the different parts and pieces of it seem to be important?
Yeah, I think that goes down to finding the right provider. I think that it is a little bit of a personal choice. You have to find who you gel with, right? And who you feel comfortable discussing everything with. It is helpful. I think sometimes, especially if have been in pain for a while, to have some sort of story beforehand that not everybody, of course, has to do this, but if you're feeling that way, it might be beneficial to almost have like a pain diary and to just make sure that you highlight some of those points that we mentioned. So like, when did your pain start? Where does it hurt? What does it feel like? How often do you get it? How long does it last? I think as long as you make sure that you include all those things, it will make it easier for you and the provider. But again, I think it's really a personal choice of who you feel comfortable with. And, you are the driver of your own health. So make sure to be your advocate.
When Dr. Levy and I work with our students, one of the things I share with them right off the bat is that every patient who has chronic pain has written a novel. And that novel has many, many chapters. And you can't skip to the middle of the book. You can't skip to the end. You have to go through it with them chapter by chapter by chapter. And if the practitioner you're going to go through has made the decision to take care of patients in pain, then they will have that degree of patience. That's the bottom line. And they have to, because, and the pain diary is an incredible help. So.
Okay. It's very helpful. I'm excited to mention too, and you just mentioned it, that you're teaching students, and I know I said it in your bio, but that was a question that came up in a talk I was in earlier, is why are we not teaching dental students about this kind of pain? So thank you guys for doing that work, because it's really, really important. This is another question that I thought was interesting. Any suggestions on navigating the specific language that a prescriber must hear in order to meet insurance dictated criteria?
I
That's
guess
the toughest question of them all.
Yeah. I think that that's a tough question, just because it's so hard dealing with insurance in general. But I will say that I guess it depends on the patient's diagnosis, of course, and that if things get rejected, whatever they might be, you can always write appeals and say the patient has tried this treatment and they've tried this and they've failed this and they've tried that, and they have done X, Y, and Z and that sort of thing. And just providing notes and going back and unfortunately appealing is probably the only right way to do it.
Dr. Mansdorf, somebody wants to know if you're a novelist. You sound like one.
You should be.
That's a great question. He does sound like one.
Thank you. Can I have a note from my wife?
I'm trying to go through and see what else we have not asked. I think we might have gone through most of these. This one, I don't know how, if you'll be able to answer it. What about facial pain related to rhinosinusitis, particularly chronic allergic rhinosinusitis that can present as pain in the cheeks, upper jaw, and upper molars?
Dr. Levy has a 150 slide PowerPoint on that.
We do, yes. So
on that.
Yeah. So
almost as painful as the rhinosinusitis.
Yeah. So 90% of self-diagnosed sinus headaches are actually really migraine that are misdiagnosed as some sort of sinus condition. So rhinosinusitis actually rarely presents with just facial pain. And if it does present with facial pain, often patients will have fever and or purulent discharge. It's confusing because migraine and other facial pain conditions can present with autonomic symptoms, as Dr. Mansdorf was talking about a little bit. And that can include, nasal congestion and rhinorrhea, meaning just, like discharge coming out of your nose, but it's not necessarily that green goop. It's more of like just a clear snot, essentially, right?
So that's an autonomic sign as opposed to an infectious sign.
Right. So I would say that, and you can look, there's been many studies that have seen that patients have been misdiagnosed and as a result hadn't gotten the wrong treatments. They've had, they've been given antibiotics and steroids many times. They've also had sinus surgery and they didn't have any relief. And then once they treated them with migraine medications, the pain actually went away. So it's not actually that common to have facial pain associated with rhinosinusitis. It's possible, but it's not that common. Okay. So that's, I guess, what I would say.
Excellent. Okay. Well, that turned out to be very appropriate. This is a good question. I didn't have a comprehensive workup with being diagnosed with glossopharyngeal neuralgia. So how do we ask for other tests? So as patients, how do we go into the doctor who knows, assuming, that person knows more than we do, and ask for other tests?
So I guess there's a few ways of going about this.
Mm-hmm.
You could say, I've been diagnosed with glossopharyngeal neuralgia, but is there a way that we can confirm that, or can we rule out other conditions? Because I will say with a lot of these conditions, as I'm sure everybody here knows, including the person asking the question, they're kind of like invisible pain, right? You don't really see it. It's more like based on your description. So glossopharyngeal neuralgia, there isn't really any specific, unless a brain MRI shows specifically, the nerve and the blood vessel touching, which it doesn't often do, it would really just be based on the patient's description of their pain and how they responded to the medications. And even if they don't respond to medications, it still is probably going to be based on their description. But it is important still to order imaging and blood work and that sort of thing to kind of rule out other conditions that might be mimicking this pain.
Mm-hmm.
Often glossopharyngeal neuralgia is an elimination diagnosis. You have X number of potential diagnoses on the list, and as you wipe them all out, that's where you end up. So if this is evidence-based medicine, it's as evidenced by, and here the responses be, is evidenced by a clear CBCT or CT, a clear MRI, bloods that are negative, no, and then you just keep going down the list, and then that's where you end up.
Okay. Interesting. Dr. Mansdorf, you may be able to answer this question with your interest in pain. Dr. Levy, you may be as well. Is it normal to have TN 1 and 2, which people refer to those differently, classical TN, atypical facial pain, plus pain in different parts of the body like legs, lower back, and neck? Is that common?
Normal has such a wide range.
Sure.
Of definitions. So does a patient have fibromyalgia? Is it actually TN 1 or 2? And what's the pain in the other part of the body from? So normal, it's not something that I'm comfortable saying yes to. Okay. I'm not familiar with that being the case. Dr. Levy, if you want to agree or disagree.
No, I agree.
Absolutely.
Yeah, I think that's true. I think normal is a hard way.
Sure.
A hard word to use.
Sure.
Yeah.
This is an interesting question. Do you see cases of people with increased TNP, which I think is trigeminal neuralgia pain, after COVID vaccine or having had COVID? Have you noticed any, even anecdotal?
I have not. I have seen other things associated with COVID, but I haven't seen an increase in trigeminal neuralgia pain. I don't know, Dr. Mansdorf, if you have.
Oops, sorry.
It doesn't mean that, it hasn't happened. I just haven't seen it.
Sure. Okay. We have about 2 minutes left. So I am going to ask one last question. Did you ever encounter a trigeminal motor neuropathy, V3 spasms accompanied by pain?
I definitely do see trigeminal neuropathy often.
Mm-hmm.
Usually when we see it, I think we often see it more in the mouth. We'll see it as, this tooth hurt, and then they did all these treatment and the tooth ended up getting extracted, like that lady that we were showing where her tooth was extracted, and then it moves on to different areas of the mouth. Regarding, and then separately to that, we'll also see patients that come in with muscle spasms and pain associated, or more of like a myalgia. I haven't really seen something where I would consider it a trigeminal motor neuropathy.
Okay.
I will say though, as trigeminal neuralgia used to be called, or sometimes is called, tic douloureux, and that's supposed to be believed to be the muscle spasms associated with the pain associated with trigeminal neuralgia. So I don't know if that is maybe what they are mentioning.
Yeah. Okay.
That we have seen.
Well, that is going to have to be it for us today. Thank you, Dr. Levy and Dr. Mansdorf, for an incredibly informative presentation. I loved the interactive nature of your talk and that you added that element so that you could hear from the attendees. Thank you for doing that, and thank you for taking the time to answer all of our questions.
We consider it an honor.
Yeah, thank you so
Thank
much
you.
for having us.
Thank you both. We're really happy you were here.